Hi everyone, thank you for joining us today at our May Lunch and Learn. May is Better Sleep Month, and we have Dr. Jack presenting from Sleep Solutions here at Good Shepherd. I'll turn it over to him.
I'm Dr. Jak Ni, the sleep doctor at Good Shepherd Sleep Solutions. I'm a medical director of the sleep lab, and I travel there once a month, but we do have a nurse practitioner that's there all the time, and we run sleep study pretty much all the time as well. So I want to talk to you a little bit about sleep medicine today with a concentration on sleep disordered breathing. So a little background. I graduated from Georgetown University School of Medicine long time ago, 1990. And then I did my residency at Allegheny General Hospital in Pittsburgh, Pennsylvania. Then fellowship at Medical College of Georgia in Augusta. And I've been practicing in the Northwest here since 1998. So sleep medicine, it's relatively a new field. It's probably started in 1980. It deals with all types of sleep diseases, disorders associated with sleep, such as sleep disordered breathing, insomnia, hypersomnia, which means sleepiness, such as in narcolepsy and other sleepiness conditions, circadian rhythm disorder. Circadian is a daily the clock that governs the sleep-wake. The disorders include advanced sleep phase syndrome, delayed sleep phase syndrome, essentially people going to bed at the wrong time, waking up at the wrong time. Parasomnias are abnormal movements at night, such as sleep talking, sleep walking, sleep eating. And then periodic late movement of sleep, which is usually associated with restless leg syndrome. There are, of course, many other disorders, but they are less common. So today we're going to talk mostly about sleep disordered breathing. Why? Because it's very common and dangerous of all the different types of sleep disorders, and also very treatable. Sleep disorder breathing starts with snoring, shallow breathing, stop breathing, intermittent breathing, and hypoventilation, which means shallow breathing to the point of oxygen level dropping and carbon dioxide retaining. Obstructive sleep apnea is due to closure or narrowing of the upper airway. As you can see, I think you can see my cursor here. Normal air passage is on the left. You see opening for air to come in through the nose or mouth and then traveling down to the lungs. But on the picture on the right, you can see the soft palate, the back of the tongue, blocking the air passage, causing obstruction in airflow. What we see during a sleep study is this. This page here is 5-minute recording of sleep, which you would see when you go to have a sleep study in a laboratory. We monitor brainwave, heart rhythm, but I'm gonna show you this breathing pattern, which is this line here in blue. Up and down is the breath. So you see 3 breaths there and a pause, and then breathing there and a pause, breathe, stop, alternating. And then we have this line here, which is chest wall movement and abdominal movement. So what you can see here is while there was no airflow, we still can see that the chest wall is moving up and down still, telling us that the patient is trying to breathe but unable to breathe. And the only times that this patient can breathe was when he or she woke up from sleep, judging from the brain activity, where I highlighted them with yellow. You can see increase in brain activities. So this patient has to wake up to breathe. And then there are shallow breathing, what we call hypopneas, are these. As you can see, the airflow marked in blue is less than the baseline airflow, also causing awakenings from sleep. And then there's another rarer type of sleep apnea called central sleep apnea, where the person stops breathing, not due to obstruction, but simply due to the brain not telling lungs to breathe. So you see no movement in chest or abdomen. We gauge sleep apnea by how many times the person quits breathing per hour. 5 to 15 is mild, 15 to 30 is moderate, and greater than 30 is severe. It's very common, up to 4% in men and 2% in women. Center of Medicaid Medicare, or CMS, budgets for sleep apnea for 25% of patients having sleep apnea. That's what Medicaid Medicare thinks their population has. So it's very common. 1 out of every 4 Medicaid Medicare patients are expected to have sleep apnea. Sleep apnea causes problems. The apnea causes low blood oxygen level, high carbon dioxide level, obviously when you're not breathing. It leads to irregular heart rhythm and abnormal functioning of the heart. Sleep apnea causes arousal from sleep, which then raises chemicals in the body to increase stress. And long-term, sleep apnea leads to stroke, high blood pressure, heart failure, coronary artery disease, and death. Here's a case of severe hypoxia, lack of oxygen. This patient, you can see her oxygen saturation went down to 6%. That's pretty much unheard of, but we did see it in this one patient. The technician actually went in and thought the pulse oximetry on the finger was malfunctioning. As you can see in a small note here that the technicians check on the pulse oximetry, but it's not malfunctioning. The patient oxygen level was actually that low. As we can see here in the oxygen tracing the whole night, it did come down here during REM sleep and again here and here. So it's the normal. It's real. This patient stopped breathing here. Again, same as in the first slide I showed you, first image, and you can see the chest wall and abdomen going up and down, trying to breathe. And the same patient on Cpap, the next night, we had her come back in wearing the Cpap, and you can totally see the difference. Here's her breathing, oxygen level staying up there, 92, 93%. And I'll explain to you later how a Cpap machine works. Sleep apnea is tied into many other conditions: high blood pressure, diabetes, lipid disorder, and of course obesity. Again, prevalence of sleep apnea is pretty high. In patients with high blood pressure, it's as high as 50%. And if you look at patients with what we call drug-resistant hypertension, requiring at least 3 medications to control high blood pressure, you find that 83% of those patients have obstructive sleep apnea. So it's very common for primary care physicians to refer patients with high blood pressure for the sleep study. We can even reproduce it in dogs. Dogs were studied by putting tracheostomy on the neck and then block off the air passage and have the dog breathe only through the tracheostomy tube. And then what they do at night is they block it intermittently, simulating sleep apnea, and they find that dogs develop high blood pressure almost right away. And then if they let the dog breathe normally the next few nights, high blood pressure went away. So sleep apnea is the most common identifiable cause of high blood pressure, and treatable, correctable as well. Other causes of high blood pressure include kidney disease, hyperaldosteronism, which is actually the second known cause of high blood pressure, but it's way behind sleep apnea. So it's less than 1%. Same as pheochromocytoma, a type of cancer. Here's another sleep study of a patient with sleep apnea showing heart rate rising every time the person stopped breathing. As you can see here, the heart rate, this black line, it's up and down like a roller coaster, because the person woke up startled. So the heart rate jumps up and then slows back down, but then went back up again with the next apnea. And you can see oxygen level dropping with every time the person stopped breathing. And sometimes sleep apnea can lead to atrial fibrillation, irregular heart rhythm. Here you can see how sleep apnea affect heart rhythm. When we blow it up to 30-second page, we can see EKG here. Heart rate was regular, and then there's a pause here for about 3 seconds at the end of the apnea, and then recovered with a really fast heartbeat. This patient went into atrial fibrillation right here. Heart rate went a lot faster, from 63 to over 100 because of this apnea here. But then it came back down. Whereas this patient went into atrial fibrillation and stayed in it. Due to this long hypopnea, shallow breathing, heart rate jumped up and then went into atrial fibrillation and never came down, staying at over 100 beats per minute. Atrial fibrillation, of course, is dangerous. It can cause blood clot. It impair heart function. Here's one study from 2004 showing that 50% of patients with atrial fibrillation actually have sleep apnea. And if you treat sleep apnea in patients with atrial fibrillation, the chance of that person going back into atrial fibrillation will reduce by half. You see a group of people with treated sleep apnea. This is their chance of going into atrial fibrillation again, whereas people who are untreated, the chance of going back into atrial fibrillation is nearly doubled. So it's very important that somebody with atrial fibrillation get treated for sleep apnea if they have the condition. And then patients with coronary artery disease, heart attack, stroke, 30 to 58% of those patients have obstructive sleep apnea. Similar in patients with congestive heart failure. Also, treating patients with congestive heart failure with Cpap increases the cardiac function. Left ventricular ejection fraction increases from 25 to 33% on the average when the congestive heart failure patients are put on Cpap. Stroke. This study was published in New England Journal of Medicine showing the increased risk for stroke and death by sleep apnea. And it goes up with the severity of sleep apnea as well. Assuming that people without sleep apnea have the risk of 1, patients with mild to moderate sleep apnea have the risk of 1.86, and people with severe sleep apnea have 3 times the risk of having stroke. Looking at the survival rate of patients with stroke, normal people without stroke would be the top line here. People with severe sleep apnea have much reduced survival rate over 6 years. You see how they kind of die off. But if you, people with severe sleep apnea will die off a lot faster than people without sleep apnea. But then if you treat severe sleep apnea with Cpap, their survival is almost the same as that of normal people. So Cpap increased survival in patients with strokes. Okay, so what are the risk factors of stroke? For sleep apnea? Obesity, old age, male, abnormal anatomic build of the upper airway, family history, alcohol, sedative use, or anything that relaxes a person at night. Body mass index, very common. In fact, the Federal Motor Carrier Safety Administration, or the DOT, requires truck drivers with a body mass index of greater than 35 to have sleep study in order to try to reduce motor vehicle accident. Sign of sleep apnea. Snoring is the first one. Gasping for air at night, sleepiness during the day, impaired cognition like memory, concentration during the day, and waking up frequently during the night. Interestingly, a lot of people report having to pee a lot at night, whereas they don't pee as much during the day. That is a clue to the person having some type of sleep disruption. Other symptoms are morning headache, non-restorative sleep, night sweat, panic attack at night. Physical examination, you'll see increased body mass index, neck size, 17 inches or greater in male, 16 or greater in women, elevated blood pressure, and abnormal airways, such as in this lady here where you see short chin. Short chins mean the tongue is closer to the back of the throat, into the airway. There's a standard questionnaire that puts all the risk factors together to determine the risk of having obstructive sleep apnea. It's called stop bang. S for snore, loud snore. T for tiredness or sleepiness during the day. O for observed apnea, and of course that is per bed partner. P for pressure, blood pressure, high blood pressure. B for body mass index. A for age 50 or greater. N for neck size, again 16 or more for female and 17 inches or more for male, and gender, male being a risk factor. If you score 0 to 2, you're at a low risk. If you score 3 to 4, you're at a moderate risk, and if you score between 5 or 8, you're at high risk of having obstructive sleep apnea. Normally, we diagnose sleep apnea by having a person come over to a sleep center, sleep lab, which we have at Good Shepherd Sleep Solutions. Patient would spend the night and hooked up to lots of little wires, totally pain-free, totally comfortable. There is also a home sleep study that is less accurate, but more comfortable at home because the patient can sleep at home. And sometimes we use overnight pulse oximetry to screen for sleep apnea. It's not diagnostic, but it can suggest that the person may have obstructive sleep apnea. Hookup in a sleep lab looks like this. You have electrodes on the head to detect brain wave. You have airflow detector at the nose, snore microphone at the neck, chest belt and abdominal belt to tell us the movement, EKG, pulse oximetry, and there are also leg leads to pick up leg twitching. Beds are comfortable. Sleep lab beds are not hospital beds like some people think. Sleep technician sits in the control room. They don't sit by your bed looking at you all night. They can see the patient through infrared camera. They can hear from what patient has to say through the intercom. Home sleep test involves taking the equipment home, usually about this size, with the airflow sensor at the nose and a belt to show the movement of the chest and abdomen, and then a pulse oximetry on the finger. They'll pick up airflow, respiratory effort, oxygen saturation, heart rate, snore, and sleep position, which sometimes is important. Some people stop breathing only when they're on the back. What we see from home sleep test is this. We can see airflow, and this patient does have sleep apnea, pauses. We see chest and abdominal rising, falling. We see oxygen saturation, heart rate, and that's all we see from a home study. Treatment. Cpap is a primary treatment of obstructive sleep apnea. Cpap stands for continuous positive airway pressure. Continuous meaning it blows all the time. Positive means that it blows instead of sucking air. It blows air in. And that air pressure expands the throat, keep it inflated, just like a car tire. You put air in there, it stays open, inflated. Machines have gotten a lot smaller and quieter. These are common machines. In fact, the one on the left just came out a month ago by Philips Respironics. It's called Dream Station 2. And there are BiPAP machines too, but we're not going to the different types of machine. Basically, regular CPAP is very effective and effective in 90% of obstructive sleep apnea patients. Mass is very important because the part that's actually touching the patient. Generally, there are 4 categories of mass, ranging from nose pillows going into the nostrils a little bit, nasal mask covering the nose, full face mask covering nose and mouth, and a total face mask that covers the whole face, which we don't usually use. Different manufacturers have come out with new masks every year, trying to make the mask more and more comfortable, so they would beat their competitors. Like this ad said, the new comfort gel fits so well that people forget they're wearing it. Benefits of Cpap includes improved symptoms and quality of life, resolving daytime sleepiness, resolving frequent awakenings at night, sometimes morning headache, and it lowers blood pressure by 10 millimeter of mercury on the average. It reduces blood glucose level in the morning, reduce the chance of having stroke, high blood pressure, atrial fibrillation, heart attack, stroke. Another treatment for obstructive sleep apnea is oral appliance, or what we call mouth guard. This appliance will be made by a dentist to pull the bottom jaw forward and pull the back of the tongue base forwards as well, opening up the area behind the tongue base here. It's indicated for mild and sometimes moderate obstructive sleep apnea, and it doesn't work in severe obstructive sleep apnea. Side effects include tympanomandibular joint pain, teeth moving, salivation. So it's very important that this appliance be made by a dentist and not just be purchased online, because that could cause problems 2 to 3 months down the road. There's surgery, but over the years we learned that upper airway surgeries don't work as well, except for tonsillectomy in children, and because kids do have big tonsils sometimes, and removing them help. In adult, it's rarely, surgeries don't usually work. This procedure used to be done a lot in the past, removing pretty much everything that can be removed, uvula, soft palate, tonsils, but they don't work that well, mainly because a lot of times the obstruction is down here behind the tongue and not because of the soft palate. Moving the tongue forward by moving the tip of the chin forward is a surgery. This surgery actually works as well as CPAP machine, but it's very extensive. It involves moving forward all these pieces, the maxilla, mandible, and a person will go from looking like this to like this, which usually it's better. The newest is hypoglossal nerve pacing. Hypoglossal nerve is a nerve that make the tongue stick forward. Okay, so this works on the basis of making the tongue stick forward every time a breath is taken. So it involves having a pacemaker implanted in the chest with a wire going down to respiratory muscle to know when the respiratory muscle contracts, and send that signal to the tongue muscle to make the tongue stick out. It's actually pretty effective. And then the patient would have a remote control to turn the pacer off during the day, so he or she doesn't walk around with the tongue sticking out. And it's actually very hard to talk when the pacemaker is working. Okay, so that's obstructive sleep apnea, and I thought I'd finish off by quickly going over sleep hygiene, because that would help with all types of sleep disorders, especially insomnia. So first, thou shalt not stay in bed for too long. This is very important, and this is what we find a lot in patients with insomnia. From the time you go to bed to the time that you wake up, it should not exceed 8 hours. And that's because human beings are designed to sleep about 8 hours at night. So any extra time in bed is going to be awake time. Okay? It's very common that we see patients with insomnia spending 10 hours in bed, and there's no way in the world that insomnia can be corrected, because there are always going to be 2 hours that the person will have to lie awake during the night. Avoid daytime naps. Of course, that's pretty obvious. Actually, daytime naps are okay if you account for them at night, like siesta that you see practice a lot in many countries. But what happened there is those people sleep less at night. They go to bed later, and the total sleep is still the same. Maintain the circadian rhythm. Very important. You should wake up. If you have insomnia, you should wake up the same time every day. The wake up time is the one time during the day that everything's going to evolve around. Bedtime is less important, and that's because going to bed can be punctual, but falling asleep can be any time. A person has no tight control over the time, the falling asleep time, but the person has full control over awake time because of he or she can set the alarm clock. So we start there when treating insomnia. Set the alarm clock, get up the same time every day. Go to bed 8 hours before the get up time. Very simple, just two things. That treats 90% of insomnia. And then there are other factors like alcohol that can wake a person up after 2 to 3 hours of sleep. Stimulants, coffee after lunch can last into the evening, causing insomnia. Feeling hungry at bedtime, feeling cold, any discomfort can disrupt sleep. Cigarettes, nicotine is just as alerting as caffeine. So cigarette smoking should not be done in the evening or especially near bedtime. I mean, we have patients that wake up during the night and unable to sleep, and yet they smoke. That's just not going to work. Exercise helps if it occurs about 5 hours before bedtime. Keep bedroom comfortable, dark. Keep the noise down. All right, so hopefully everybody sleeps well. And do remember that falling asleep while driving at the wheel is very dangerous. This cartoon showed the first fatality as a result of falling asleep at the wheel. And that's all I have for sleep apnea and sleep hygiene. I will let people ask questions.